Welcome back to the second half of the afternoon section today. I hope you all enjoy a refreshing tea break. The next speaker that I would like to introduce to you is Professor Elizabeth LOBB. She is the Professor of Palliative Care in Allied Health based at Calvary Healthcare and is the Adjunct Professor in the Faculty of Medicine at the University of Notre Dame and the Faculty of Health in the University of Technology in Australia. Professor LOBB has worked clinically as a bereavement counselor and educator for 24 years and has been working on her meditation practice for 20 years. She will present on the topic, The Gift of Grief and Sorrow, Bringing Wisdom and Compassion to Death and Dying. So let's have a round of applause to warmly welcome Professor LOBB to the stage.
Thank you very much for the opportunity to speak this afternoon. It was a great honour to be invited to be here today, but I must say, having heard the presentation so far, that I stand before you this afternoon with the beginner's mind. And I hope in my presentation to be able to show that when we work with people who are dying and the people who care for them, that as a therapist and as a counsellor, beginner's mind is a very good place to start. So I always like to begin by defining my terms. So palliative care is an approach that improves the quality of life of patients and their families facing life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and of course, significantly in what we are looking at today, spiritual. Specifically, it provides relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. It intends neither to hasten or prolong or postpone death. It integrates the psychological and the spiritual aspects of the patient care. And we say in palliative care that it is the patient and the family who is our unit of care. And of course, in today's nuclear society, the carer can be a neighbour, a friend, a colleague. And so when we talk about family, we talk about the people who surround and care for the person who is dying. It offers a support system to help patients to live as well and to improve their quality of life until the moment of death. And it offers a support system for the family to cope, both during the dying process, where we refer to anticipatory grief, through the death, and then afterwards to living. So why do we do it? And I like this quote very much from Dame Cecily Saunders, who was the founder of the hospice movement in the UK. And she said, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." I have been working in palliative care now for over 30 years. And it's interesting, one of the most common questions I will get will be, "How could you do this work? It must be so sad, it must be so depressing." And my response is that my work affirms life. It teaches me to live well each day. It teaches me to tell those that I love today that I love them. It teaches me to appreciate every moment that I have. And so I came to this work 30 years ago, but I came to Buddhism more recently. Perhaps it may be interesting to know that I was brought up Catholic, and at a very early age I wanted to be a monastic. But my life took a different direction. But what I want to talk about today is how, for me, as a counsellor, as someone who has sat with people who are dying and who has sat with their families, what aspect of my Buddhist practice has sustained me and helped me during this time, And I think that some of these techniques can apply to all of us as we sit here today. Just getting the technicalities right here. What I love most is this very early Buddhist story, which I'm sure many of you are familiar with, and I'm going to tell it again. It is the story of Kisa Gotami. And in this Buddhist story, a young woman follows almost a fairy-like tale path from birth in a poor family to marriage to the only son of a wealthy family. She was not treated well by the wealthy family of her husband until she bore them a son. Then she was accepted and respected. Things couldn't be better for her. But then tragedy strikes. Her son, just at the age when he had begun to run around and have fun, he died. Distraught, she took the child's body and searched for a doctor with the right medicine to revive him. She was laughed at and mocked by those who saw her until finally a man told her to go to the Buddha. She asked the Buddha if he could help her. To her delight, he said, "Yes, I can help you." What he would need from her was just a simple mustard seed from the nearby village. In India, mustard seeds would be practically in every house as they are used for a spice. She was elated. This would be so easy, she thought. But the Buddha told her, "You must get the seed from a house that has not known death." Sure, she thought, and quickly went on her way. At the first house, she asked for the mustard seed, and when it was quickly offered to her, she asked, "Has there been a death in this house?" The kind villager nodded and told the story of a lost uncle or cousin. The same happened at the next house, and the next house, and the next. As she travelled from house to house and heard story after story, her sense of aloneness in her grief began to subside. No house is free from death, she realised. She finally let go of her son, laying him in a forest nearby, and returned to the Buddha. The Buddha asked her, "Do you have the mustard seed?" "Dear teacher," she replied, "I do not. But I saw that the living are few and the dead are many." This story moved me very much because it is so true of the work that all of us do and the path that we take every day. But often, I think it's unusual that grief is not addressed in contemporary Buddhism that often. I was once told that the shortest line in the Bible was, "Jesus wept." Perhaps it is looked on as a weakness of character, or that we haven't practiced strongly enough, that we are so overcome with emotion, or that we are so attached to this person that we have loved and is now no longer with us. But we all face loss, and perhaps we can accept it as a gift, although for most of us it is unwanted and often a terrible one. But to deny grief is to lose the opportunity to develop wisdom and compassion. It is a vital part of our very human life, an experience that can open compassion and an important phase of maturity, giving our lives and our practice depth and humility. As Roshi Joan Halifax said, "The river of grief might pulse deep inside us, hidden from our view, but its presence informs our lives at every turn. It can drive us into the numbing habits of escape from suffering, or bring us face to face with our own humanity. And this is the very heart of Buddhism." I like this poem very much from Gregory Orr. The Year of Being is a collection of mindfulness poems, and you are sent one every day. And I received this one, and it spoke to me very much. "Grief will come to you. Grip and cling all you want. It makes no difference. Catastrophe, it's just waiting to happen. Loss, you can be certain of it. Flow and swirl of the world, carried along as if by a dark current. All you can do is keep swimming. All you can do is keep singing." So the focus of our gathering over the next 2 days is to look at Buddhist informed practices And if we look at the therapeutic alliance, the literature tells us that it accounts for a significant amount of variance in counselling outcomes. However, the clients themselves don't emphasise the effectiveness of particular techniques or methods. Instead, they primarily attribute the effectiveness of their treatment to the relationship with their therapist. And therapist variables account for more outcomes than therapy style. And it is these therapist variables that I want to speak to this afternoon. Rachel Remen has, I think, put it so beautifully when she said, listening creates a holy silence. When you listen generously to people, they can hear the truth in themselves, often for the first time. And when you listen, you as the therapist listen, you can know yourself in everyone, which raises this concept of interconnectedness between us as therapist and client. So firstly, if we consider the significance as a therapist of having a meditation practice, what does this bring to our relationship with our client? In being with a patient, it brings openness, kindness, and acceptance, a staying in the moment, no matter how painful and challenging that may be. Not attaining, beginner's mind, not trying to get anywhere or get the patient or the carer to somewhere. Not knowing. Something has to unfold that cannot be known at the beginning. It is individual to this client, to this person who is dying or who has died, to their relationship, to all aspects of their life. It can create a sense of space. The sense of space we have developed in our meditation, we bring into the relationship with our client. It allows what needs to unfold, a sense that there is time enough for what needs to be experienced. And the mind is empty, the therapist's mind is empty. Because what we have in mind, where we are and what we are bringing into the room, impinges on the patient or the carer. I have a practice when I walk onto the palliative care ward and before I walk into a room, where I will pause and stop and gather myself and take a couple of deep breaths so that at that moment I can be fully present for whatever may be behind the door or behind the curtain, because I don't know. And we know that the influence of our meditation practice on us generates a sensitivity to fluctuations in our relationship. We are more able, more nuanced to pick up changes. As we heard earlier, we're looking at tone of voice, the position of the body, many aspects of the client that we are now more open to. I think importantly, it gives us a greater capacity to remain aware of the negative processes that may be unfolding without losing our ability as a therapist to self-reflect. And it gives a greater capacity to repair by being less defensive and relying less on rigidly conforming to a particular treatment mode. So we are assessing and changing at every moment to be in a dance almost with our patient or with our client. The quote that has been read this morning on mindfulness, and I want to refer this to bereavement support and how it may work. John Kabat-Zinn, as we have heard, says that it means paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. So how is this helpful for us as clinicians or clients in the Therapeutic Alliance? It helps us to strengthen this alliance. It helps us in self-care and dealing with often the overwhelming pain and suffering that is associated with grief and trauma. It allows us to let go and cultivate an attitude of non-attachment, which is the fundamental part of practicing mindfulness. It's about allowing things to slow down and letting our experience to be what is, observing it moment by moment. And it requires of us and of our client self-compassion, stemming from this curious, non-judgmental attitude, and as I keep coming back to, having a beginner's mind. So what are some effective mindfulness principles for bereavement support? I think importantly, really significantly, it reminds us that we are all in this together. Death happens to every human being. It is about belonging, being part of, and being heard and acknowledged. We are one with our client. We need to acknowledge immediately that most clients, most human beings have the capacity to self-heal, to self-recreate after the experience of death. And this means that as professionals, in whatever level we are working with the dying or with the bereaved, not interpreting their grief experience, we know from the very basic training in grief that it is a normal response to loss, that it is very individual, that it is influenced by the person's experience of previous losses, that is indeed influenced by their culture and their background. But rather for us to have the patience and respecting that difference and supporting them in it. Research has shown that health professionals who have a balanced mindfulness practice demonstrate a greater ability to be witness to the overwhelming pain of their clients in a balanced, respectful, empathic, curious, and non-judgmental way. And so conversely for the client, it increases their choices and capacity for self-care due to managing often what can be overwhelming emotions and stressful times in a more tolerant and self-compassionate way. And it also gives greater potential for self-empowerment and finding alternative integrative ways of experiencing their grief journey. We have heard a lot about mindfulness-based interventions, and they have been applied to a range of psychosocial and medical problems. However, little has been done in the area of families who have experienced bereavement. There have been several studies done in individuals with potentially terminal illnesses and being found to reduce mood disturbances and stress in cancer patients, improvement in quality of life, stress symptoms and sleep quality, certainly in early stage breast and prostate cancer. But studies to date haven't shown improvement in mood. There has been some earlier work done on a mindfulness intervention in bereavement by Cacciatore and her colleagues, but it is in the early stages of development. So why might mindfulness-based interventions be helpful in bereavement? Clearly because of its present moment orientation. Focusing on approaching rather than avoiding the painful affective states of our clients. The ability to increase the tolerance for fluctuating feelings and thoughts, and a sense that there is support through this, that this is a journey that is not being undertaken alone. But also for us, it brings great benefits because it attends to our own emotional responses, and it has the potential of increasing our own compassion and decreasing any avoidance that we may experience, which is natural and human in the face of intense suffering. There are many psychotherapeutic options that are available at end of life. I have been doing a lot of work recently with dignity therapy, which is being developed by Harvey Chochinov in Canada. But many of the others, insight-oriented therapy, interpersonal therapy, group supportive psychotherapy, existential supportive expressive therapy, many of them perhaps would say that they have drawn from some Buddhist principles. Logotherapy developed by Frankl, life review, presents us with many opportunities to work with our client to look at what has happened in the past, but then how to bring them to the present moment, to what is happening and what they are experiencing. For me, the four immeasurables, or they're sometimes referred to as the Brahma Viharas, give me a map on how to respond. We have metta, or love, karuna, compassion, mudita, sympathetic joy, or upekkha, equanimity. And I have to say, I place a lot of my energy on equanimity. And when we work in an area that is challenging, coming back to our center, to our breath, to our balance is so important. I've heard them referred to as immeasurable because it is said there is no end to their cultivation, and that with practice in all of us, these qualities continue to expand and to embrace our lives as clinicians and those of our clients. I think this sums it up beautifully. A peaceful heart gives birth to love. When love meets suffering, it turns to compassion. When love meets happiness, it turns to joy. So how can we use these as core clinical values in grief counselling? So metta, or love, is the foundation, and the other three are providing important developments. Love and acceptance of the person as they are at this moment, as they come to us, for all their distress, their tears. Compassion, so for us not flinching in the face of suffering and the acceptance of suffering. We know that equanimity supports compassion, but so important to have those wings of wisdom underneath that. And sympathetic joy is important in that we want to amplify a positive effect in our clients. So let's start with loving kindness. Words that have been used to describe it: kindness, acceptance, gentleness, being straightforward, humble, unburdened, peaceful, calm. To cherish the client, to wish them peace and a sense of ease. And I love this quote: to reteach a thing loveliness is the nature of metta. And we can model metta by manifesting it in our clients, and that this in turn can be internalized in our clients. This sense of being held, this sense of being valued, this sense of being appraised and being part of the bigger picture. But we need to be careful and to note ways, and this happens so often, in which clients are harsh with themselves, and to be able to help them to respond to this, particularly when feelings such as guilt arise, where I may have a carer who will come to me and say, I should have listened sooner when he said he was feeling unwell. Why didn't I tell him to go to the doctor sooner? It's my fault that he's now sick. It's my fault that he's died. And so how we can use this sense of loving kindness to bring that sense of self-compassion and self-kindness to our clients. Compassion has been described as a quivering and a trembling of the heart in response to another's pain. And it is not something that is weak. It is the strength that arises out of seeing the true nature of suffering in the world. And if we as therapists feel that our hearts will break, that we will be overwhelmed, that we cannot bear what is going on, and that we find it difficult to open pain, yet that is the basis of our compassion and our compassion practice. So the first step is to acknowledge that suffering, and then for us as therapists to open to it. So often working in palliative care, we hear the expression burnout, compassion fatigue. Many seminars are held, we hold them at the hospital. It's almost as if people are afraid. We talk to our doctors, we talk to our nurses, and it's the first thing that they will talk about. I'm afraid if I get too close, I will burn out. I'm afraid if I open myself too much to my client's pain, I will be unavailable to the next patient that walks in the door. But a palliative care doctor, who is also a Buddhist practitioner, wrote an article that she challenged this concept. And she said that compassion fatigue assumes that there is a limited well of compassion in each of us, and that once it's used up, either we must replenish the well or move along without it, devoid of our compassion or with impaired compassion. Alternatively, she says, if that energy is spent wholeheartedly engaged in what is in front of us, the very suffering that is in front of us, rather than protecting ourselves and judging and labelling the other, we might find that we are not so tired emotionally and that we are not as burnt out as we think we are. And we find that our compassion is not a finite entity that can be used up, but in fact is infinite, immeasurable. And it can arise anew in each situation, each moment, since it is a response, if we choose, to what is in front of us. It's what we do, not who we are. And forgetting the self, and much has been said about this than I can speak to, but for those moments as a therapist when we Forget who we are. Throw aside our title. Throw aside the next meeting we have to go to. Throw aside the key performance indicators that we need to be ticking off. And just let the world of the client who is in front of us unfold, rather than think that it's we who must manage and unfold the whole world. Then we begin to save energy and burnout lessens. However, and there is really a word of caution here, this is not in any way to say that time for the self and care of the self is not extremely important when we work in this area, particularly in end-of-life care. We need to have individual support, adequate sleep, good nutrition, help and care and support from our colleagues, and time for our family and friends. And I really commend to you this article that Lisa published in the Journal of Palliative Medicine. I'm sure many of you may be aware of Kristen Neff's work looking at compassion and burnout. And in this she includes self-kindness, a sense of common humanity and mindfulness. And as we've seen that both mindfulness and self-compassion involve promoting an attitude of curiosity and non-judgmental towards one's experience. So that's talking about us, not just our client's experience, but what we are experiencing moment by moment as we sit in the presence of this pain and suffering. And so by being mindful, it allows us to not over-identify with the problems that are presented to us day by day. It allows us to connect with others rather than isolate oneself. I can remember when I was graduating as a bereavement counsellor, my final assessment was videotaped. And I was doing we had to role play for one another. And one of my colleagues chose a particularly painful, difficult scenario to present to me. So I thought I was doing really well. And at the end of the session, my examiner said to me, "What was that like?" I said, "Honestly, it was like walking backwards through honey in high heels." And he said to me, "Let's just pause the tape here." And there was a moment when I did this. And I sat back in the chair. And he said, "What were you doing?" And I said, "Well, I will go 90% of the way to meet my client where they're at. But that 10% is for me. I need that to take care of myself so I don't burn out." And he said, "Liz, that 10% will be your burnout, because you will put so much energy into protecting that part of you that does not want to open, that will be your burnout." And when I relate that stories to my colleagues, to my doctors, to my nurses, to my social workers, they, "That is really difficult. You mean if I truly open to the pain and suffering of the person sitting in front of me, I'm not going to burn out, that I still will have more to give, that I won't be completely empty?" But for me, it was a very powerful lesson. Equanimity. Oh, this is my challenge. This is my challenge. Defined as a spacious stillness of the mind, a radiant calm that allows us to be present fully with all the different changing experiences that constitute our world and our lives. I needed it while you were all out having tea because I was pacing up and down inside. What is my phrase? Remember to breathe. I use that one a lot. So why is having equanimity so important when we are working with death and dying? Because it allows us to cultivate a mind that is willing to stay with the client's trauma, their sorrow, their shame, their guilt, their regret, their fear, their anxiety, their loneliness, their anger, their envy, their jealousy, all of the emotions that we as therapists know are normal responses to grief. But this equanimity, this balance, allows us to stay put. I have a few more strategies as well, I have to confess. If I know I have a client who's coming in who's going to be particularly difficult and anger is something I really struggle with, I have a padded jacket hanging on the door. Back in the 80s, they were really fashionable, and it's a bit difficult today to get a jacket that's got good pads in it. But I would put my jacket on because I felt as if I had some sort of level of protection in dealing with my angry client. And so there are other strategies as well, but I continually come back to equanimity, to work on balancing, keeping myself in balance, keeping myself open to whatever is happening in front of me. Mudita, I thought, was really interesting, to bring joy into bereavement, to bring joy into death and dying. But we know that the patient and the bereaved client responds to happiness and joy. It's as like a child will respond to the delight that their parent shows in them. And they will respond to the delight that we as therapists will show in their progress. Because our clients need to know that it's not always going to be this painful, that they're not always going to feel this bad, that life is not always going to be so difficult. And certainly we avoid the language that you will move on, that you will get over, because for many people, life will never be the same. And it will be a new normal, a different normal, but it will never be the same to how it was before that person died. And so as therapists, we want to amplify positive emotions in our clients. And so our clients will feel felt in a way that is deeply valuing, that someone actually wants us to thrive and be happy, that someone is there who can recognize the pain and know that we, like them, want happiness and don't want to suffer. When someone rejoices in our happiness, we are flooded with respect and gratitude for their appreciation. I love the work of Barry Magid. I don't know whether any of you have read his book, The Pursuit of Happiness. Oops, let me get that off. I think I need to just click on the screen. Yes. We know that acceptance is at the heart of Buddhist practice, but we are constantly challenged to accept change, interdependence and vulnerability as synonymous with human life. And where are we more confronted with this when we work with people who are dying, with people who are given a diagnosis of a life-limiting illness, with their carers and their family members, how to arrive at this point of acceptance. And it's not necessarily a word that I would use, but I know that perhaps we are making progress when instead of my clients saying, why me, they can say, why not me? Why not me? How am I any different to anyone else? I haven't been chosen or picked out to have this terrible experience. Barry says that the difference between truly accepting and resigning is that acceptance feels like a starting point. We now have somewhere to go, somewhere to begin, whereas resignation feels like a full stop, a stopping point. I did a study. We know now as cancer treatments get better, particularly with the introduction of immunotherapy, which is now offered for many cancers that in the past would have had a very poor prognosis. And so I did a study of patients who had a cancer that we knew would shorten their life, but they were reasonably well, they had a good quality of life. And my study was to ask them how they coped with uncertainty. How did they live day to day, moment by moment, in the knowledge that eventually this disease that they had would kill them? And I loved the quote from this man. He was a young man, 34. He had 3 small children. He had a thriving Nepalese restaurant, in fact, in the town where I live. And he had been diagnosed with mesothelioma of the lung. And so when I said to him, how do you keep going? How do you go day by day with this uncertainty? And this is a direct quote. He said, so I mean, we'll just keep on. Our kind of philosophy is a kind of Buddhist thing. Before enlightenment, carry water. And you've still got to do the same thing after enlightenment. You go to the well, carry water. So that's our philosophy around it. And much of the work that I am doing with our clients is to help them go to the well and carry water day by day. And when we asked people how they manage their uncertainty, how did they cope with the fact, how did they bring meaning to their experience, they said what was important to them was to keep life as normal as possible, that friends and family and routine were important to them. They didn't want to climb Everest, they didn't want to change the world, many of them didn't have a bucket list. They wanted to live life as normally as possible. And so my role in many of these instances is to help them go to the well each day and to carry water. So the title of my presentation today was The Gift of Grief and Sorrow. So what is this gift that I am referring to? That is a gift that we can choose to accept or not. It is the awareness of impermanence. The awareness that we too will die. We don't know where, we don't know when, we don't know how. And it's this sense of connectedness with our client in this common acceptance and awareness. And as Roshi Joan Halifax said in her book, Being with Dying, when we move through the terrible transformation of the elements of loss and grief, we may discover the truth of the impermanence of everything in our life, and of course, of this very life itself. This is one of the most profound discoveries to be made as I engage in my Buddhist practice, as I, with my beginner's mind, beginning very much on my journey. In this way, grief and sorrow may teach us gratitude for what we have been given, even the gift of suffering, and from here we learn to swim in the stream of universal sorrow, and in that stream we may even find joy. Thank you.
Are there any questions? Okay, if no, then please join me to give another. Oh, no. Okay, sorry.
Hi, thanks for that. Do you think we can use these same principles outside of grief and bereavement contexts?
Oh, absolutely. In every aspect of our life. Yeah. I guess for me in this early stage of my knowledge and study, they are the ones that I have found most helpful. But of course, we can use them in every aspect of our life, in our home, in our families, in our everyday interaction with other people, not just necessarily because we work in the health professions. Yeah. I'm sorry if I gave that impression. Yeah.
Thank you.
Any more questions?
It's a personal question. I was asked in the last 30 days for a friend who I lost 2 weeks ago, what will it be like in the end? And I wished I had been able to give him an answer. Do you have any answers to people's questions who ask that question?
Sorry, who asked the question?
The question I was asked was, what will it be like? He was wondering.
What will it be like?
What would you say to someone who asks that question?
Yes. It's a very personal question. I guess I would begin by asking them what they think, coming either from their own spiritual beliefs or their own culture, their own background. Speaking from a palliative care perspective, I think clinicians can give much reassurance. I think one of the most difficult things that a doctor can say to a patient is, there is nothing more we can offer you. There is nothing more we can do, when there is always something more that can be done. From a palliative care perspective, if someone asks that question, depending if it was an existential question or what will it be like, I could respond that we will do our very best to manage your pain if they are having difficulty with breathing, if they have concerns about their family. So it's inquiring what aspect they're asking about. One of the things we do for everyone who is admitted to our hospice, and we have a 40-bed hospice, is to ask them what it is they want at the moment of their death. Who do they want to be there? Are there particular practices that they wish to have performed? Is there particular people who can handle the body? Are there particular rituals? And so we, on admission, at the first moment of admission, we will ascertain if there are particular needs in these areas. But clinically, we will, and often it is the fear, not so much the dying, but how I will die. And so to be able to reassure someone that we will do our very best to help you live as well as you can, to manage your pain, to manage your breathlessness, to support your family into their bereavement. Because often the concern of the patient is for the family. How will they survive without me? How will they manage? How will my children cope? How will my wife cope? We can tell them, in fact, I've just done a study, interestingly, called, we asked patients who will be most affected by your death. And the ethics committee said, you can't ask that. You can't ask a patient that question. And the reason we asked it was that when someone is admitted, you write down next of kin. But the next of kin may not be the person who is going to be most affected. And interestingly, the responses that we got was, well, my daughter, her husband died 6 months ago, I'm really worried about her, or she had a miscarriage, or I have a neighbour who for 30 years has been taking me shopping and I'm worried how she will cope. And so often the question comes not so much concern for themselves but for others. So a very long way of answering your question. I guess it's an invitation to go deeper, to ask more. And one of the lines that I use a lot is, tell me more. When I'm stuck for words, tell me more, tell me more. And they do. It's that open invitation to be fully present.
Thank you, Professor, for a very beautiful presentation. I agree so much with you by your saying that your patient, we can learn so much from dying patients, that they affirm life. And my question is, how would you, in your experience, help someone? Well, they're all well and good and teach us things if they already accepted their fate. How would you, in your experience, help those who have not yet accepted their fate?
Yes. I have a story that I can tell in response to that question. When I started working in hospice care, I had one of the nurses come to me and say, I want you to go and see Mr. Smith. He's in denial. He's probably got a week to 10 days to live, but he's talking about going to his granddaughter's 21st birthday party in another state in a month's time. He's in denial. And I went in to see Mr. Smith, and Mr. Smith knew very well that he would not get to his daughter's 21st, but we sat down and we talked about, tell me about, I think it was his granddaughter, tell me about your granddaughter. What is she planning for this party? And so often and I think that's one of the challenges when we are not honest and when we don't tell the truth, because it doesn't give people the opportunity to prepare. But having offered the opportunity, having given sensitively the information about the likely progress of their disease, and we heard earlier this morning that a prognosis doesn't necessarily mean how long that person may live for. But if someone genuinely asks and wants to know, then I think ethically we have a right to tell them. But we can offer them that information, but I think it is their right to be in denial. We know that it's an ego protective mechanism. It is a way of dealing with this overwhelming information that they've just been given. So on the one hand, I would respect that, but also be open to when they might ask that question again or want more information. And so I think for me, it's about being present. It's exploring where the question has come from. Sometimes it needs to be addressed. Sometimes we need to be very practical. A young person with a family, there are legal matters, there's a will, there's things that need to be discussed. And so I would respond perhaps in the way, we can hope for the best, but if things did not go so well, what would you want? What would you want to do? And so it opens up the possibility while still allowing them to have that denial and that protection, but presenting a scenario if things didn't go well, and then begin to explore what would the next steps be.
Thank you for your beautiful talk, and it's very nice to hear your sharing on the compassion fatigue. And as a medical doctor, we we certainly might be one step forward to have the compassion failure when we have a patient who is so resistant to your intervention, keeping their myths, and also maybe just throw anger at your intervention because they feel that it's not effective. So how would you manage that?
I think, again, that is where the practice of compassion stands alongside equanimity. And so to be strong and present in ourselves, take a deep breath and to know that this is not about us personally, that this is about the fear of the patient. And I think it's hanging up our professional hat and being present to the experience of the patient, to the fear, to them wanting you to make a difference, to cure them, to make them better. And to not be taking that on as a personal responsibility, that knowing that you have offered everything there is to offer that patient. And sometimes, and I think this is very difficult, and it's not about saying there is nothing more that we can offer. It's about having that conversation that we thought this particular treatment would work better than what it has, and I'm really disappointed and sorry that it hasn't. Let's talk about what we could do next. So I think the fear for, and certainly in the literature and the research, there is a fear among patients as they make that transition from oncology into palliative care that they will be abandoned. So I think one of the messages that we can give is that you will not abandon them, that yes, this course of treatment that you really hoped would work and make things better has not turned out to be how you thought it would be. So what can we do next? And then begin to explore with the patient what their goals are, perhaps medium, short-term goals, and so that you can then work together for the next step.
Okay, maybe the last question.
By your experience, is it possible for the dying patient to practice meditation?
I believe it is. I mean, one of the things that we know that when a person is dying, one of the last faculties to go is hearing, which is why I think it is so important in certain Buddhist traditions that if the chanting, we need to make sure that we can have the monks there. We would move a patient into a room on their own, into a private room, so that we can have the monks come in to do chanting if that's what the patient wants. I believe that it is possible for the person to be unconscious, to be seemingly physically unconscious, but still able to hear. And so I think what is important at this time, that there is a sense of calm around them, that the people who are around them are calm and steady, and if it is part of their practice, if that is something that is important to them, that the people around them are reciting what is important for them or chanting. We try as much as possible to follow through with different traditions. If there are oxygen cylinders, we can't have lighted candles, so thank goodness candles with LED lights have been invented. But to answer your question, it depends on the physical state of the person. If there is some cognitive difficulty, if there is a delirium, if there has been... certainly I think we need to be very careful, and this just isn't in the dying person, but someone who has lung cancer or chronic obstructive airway disease, we need to be very careful that we're not teaching them breathing. Certainly there are strategies that a doctor can give, certain strategies to help with the breathing, but for someone who is struggling for breath, to actually ask them to focus on their breath can be very distressing for them. So we need to be very sensitive, firstly, on their physical state. But I think knowing that the hearing is the last faculty to go, there is much that can be done in letting the person know that you are there. I would encourage the family to keep talking to them, to give messages of love and support. Often much unfinished business can be dealt with at this time, when the person is able to say, I'm sorry, or I love you, or I will be okay when you're gone. So I think it depends on the individual, but it's certainly possible for us in the presence of that person to create as much of a calm, peaceful environment that for them to be in the presence of a meditative state. Yeah.
Thank you very much, Professor Lobb. Let's give a big hand again to Professor. Thank you so much. Okay, now I'd like to introduce Venerable Hin Hong and Ms. Bonnie Wu from the Hong Kong Youth Center for Buddhist Studies. Venerable Hin Hong, as many of you may know, is our center's founding fellow and the former director. He is now serving as the chairman of our new Master of Buddhist Counselling program. He is a Buddhist monk from the Mahayana tradition and is also the 45th generation lineage holder of Linji and the 10th generation lineage holder of Guiyang schools of Shan. Venerable Hin Hong teaches meditation and is also providing counseling and spiritual guide to the staffs of the Hong Kong Hospital Authority. He has many publications in Buddhism, psychotherapy, neuroscience of meditation, Buddhist education, and personal growth. Ms. Bonnie Wu is the PhD candidate of the center and also a team member of the Buddhism and Science Research Lab of the center. Her research topic is related to the Awareness Training Program, the ATP. She has published articles on Buddhist-based interventions and neuroscience of meditation, as well as books and manuals on Buddhist life education for primary and secondary schools. She is also a registered social worker in Hong Kong. The topic that they will present today is a Mahayana Buddhist teaching-based intervention awareness training program, its theoretical model and effectiveness. So without further ado, let's give a big hand to welcome them to start.
Thank you for the introduction, Carol. Our topic is Mahayana Buddhist Teaching-Based Intervention, ATP. What I'm going to talk about is to introduce to you why a Mahayana Buddhist teaching-based intervention, its theoretical model and effectiveness. I will be introducing the theoretical model, and Bonnie will be introducing to you the research model and the data. And then at the end, I will also be introducing some of our neuroscientific research that we do together with Dr. Gao and Hank, okay? So let's begin. Okay. Why Buddhist teaching-based interventions? Obviously, you now know that mindfulness-based intervention is very popular, but there's a complaint or there's a saying that these mindfulness-based interventions lack foundational congruence and apply the practice of mindfulness in an out-of-context manner, meaning that the mindfulness practice is now promoted or introduced does not somehow is congruent, does not match, is not coherent with the theory behind the whole thing. So what we are saying is that why don't we put the mindfulness practice back into the Buddhist teachings, so then the whole thing become coherent. So in fact, then we can have the whole Buddhist model of intervention, or the Buddhist model of ending suffering. However, there's two Buddhist models of ending suffering. Obviously, there's the Arahat path. Some people say it's pathological or medical, but there's in no way saying that it's good or not good. Because tomorrow I'll be introducing another model, Dharma therapy, which is also an Arahat path model of ending suffering. What we are doing is the Mahayana path, the wellness model today that I'm introducing today. So I'll be introducing another model tomorrow for the Arahat path. Okay. So the Arahat path is talking about the end suffering, particularly the ending of suffering of reincarnation. So it's based on the Four Noble Truth, and then suffering. This is suffering, the disease, the cause of suffering, the craving, ignorance, and cessation of suffering, the care, and the path to the medicine. Now, what I'm introducing to you, this is the Dharma therapy I'll be introducing tomorrow. But what I want to talk about today is the Mahayana model. So why a Mahayana model? And then we say that it's a wellness model. Why is it a wellness model? Is that instead of targeting suffering and the elimination of suffering, a bodhisattva is driven by deep compassion to save all sentient beings from suffering. So suffering is not something to eliminate. Rather, suffering is something that we use to develop compassions. And then, so bodhisattva suffering is not something to be eliminated, but it's something to develop compassions. And with wisdom and compassion, the bodhisattva would have the skillful means to deal with all the challenges he or she would face while remaining in samsara to save all sentient beings. So that's why we want to do a Mahayana Buddhist teaching models, because the wellness model of compassion and wisdom might be more acceptable to the general public when compared with a pathological or medical model which emphasizes impermanence and suffering. If you are not experienced impermanent and suffering, then you don't really want to hear about it. Then if we talk about compassion and wisdom, the packaging is much nicer. So a wellness model would aim to enhance the participant compassion and wisdom regardless of the individual problem. Therefore, a wellness model would be suitable to run in a group setting. So this ATP awareness training program is actually a group therapy. Therefore, our hypothesis that Mahayana Buddhist teaching-based wellness model could be just as effective as the Four Noble Truth pathological model, which I will be introduced, the one that we developed. Okay, so another is the textually aligned, coherent in theory and practice. Why is it important? To avoid the potential danger of inconsistencies between theory and practice, that is in the theory and how you practice the teachings. Therefore, because there's many Buddhist teachings and texts and denominations, and some of them may vary in the theory, and they have their own theories and their own practices. Now, if you take this theory from this and integrate with the other practice, then it may not really work. So, furthermore, there are Theravadyans and Mahayana, there's so many of these. So it's important if we can have a coherent in theory and practice. So adopting a textually aligned approach, textually aligned would mean that the teachings and the practices come from the same school with the same model of suffering and ending suffering. We want to make sure that both are from the same school with the same assumptions of the teachings and how to end suffering. So there are similar background in both theory and practice. That's why we want to have the model that is, come from the same text. So we came this with a called awareness training program. It's a group-based program on the Mahayana Buddhism teaching and practice. This is what we came up with. It's a new program. It's textually aligned to a Mahayana sutra, and the sutra that its theory and practice are incoherent. So this is what we intended to do, and it's a 6-week, 3 hours. We meet 6 weeks, 3 hours in the workshops, and then 1-2 days, whole days workshops. This is the program, and the foundation, the theoretical foundations come of this Charitable Sutra, which is one of the most important texts of the Yogacara traditions, which is the consciousness or mind-only school. In this school, is a source of human suffering is the result of attachment to an illusory concept of self, or you can say that ontological addictions, arising from a delusive understanding of the world. So why we would have the concept of self is because we have a delusive, we don't really see the reality of things. That's why we develop this concept of self. And then according to the Charitable Sutra, state that the cause of this delusion, attachment, is that people add on a conceptualized nature on top of the dependent nature of the real nature. So the dependent or the original nature is the things that just as they are. Then we subjectively, conceptually add on a second layer of concept and attachment to the reality. That's why we have suffering. This is according to the Charitable Sutra. So to help people to overcome this delusion and attachment, then the sutra say that all our phenomenological experience can be explained and qualified by one of the three types of characteristics. And then this is the characteristic of mere conceptual grappling. These are the concept. For example, you call it a rose, you call it a Mercedes-Benz, or you call it PhD candidates or something like that. These are conceptual that we put onto things. And then the things is called the characteristics of dependent originations. And these are the things that, for example, you have the rose, and then the petal and the stems. These are the rose itself without the names. And then on top of that, there's the perfect characteristic. These are the three types of grappling. These are the characteristics that we can experience. Through these three types of experiences, then we experience the world. Now, on top of that, the sutra said that these three types of characteristics, when examined closely, if you look at the three types of experiences closely, examine them in deep, then we'll reveal the three types of emptiness or essenceless characteristics. So that when you look at the rose and you look at the name of the rose and you find out that the name of the rose is what? This essencelessness of characteristic of the name of rose. What is the name of a person, your name? Then the name is nothing more than a conceptual idea that our mind projects onto it. However, we attach to that conceptually projected image so dearly that we create all kinds of problems. Okay, and then the essence of birth. So that means you look at the interdependent phenomena as Professor Gordon explained this morning, that it's all emptiness, and it's all interdependent. You take the whole thing apart, you will not find the self itself. You find a lot of things belong to you, but you will never find yourself. You'll find many parts that belong to the car, but you look into the car, you'll never find the car itself. That's why I say the essence of birth, of phenomena. And then ultimately is the ultimate essencelessness. That means even everything is empty, including the concept of emptiness. So if you look at these three types of essencelessness, if you look at these three types of characteristics and analyze it, you'll see that the three types of characteristics is reveal the essencelessness or emptiness characteristic of this three types. So what is the meaning of that? Therefore, by understanding the three types of essencelessness or emptiness characteristic, or the intrinsic emptiness nature, a person can gain wisdom and insight to help him or her to forego the attachment to all phenomenological experience. Of course, in Buddhism, it's because the attachment to these experiences that create the suffering that would fall within the three types of characteristics, and to therefore develop the wisdom of non-attachment, which we think is the most important of our practice, the wisdom of non-attachment. So this is the theory behind the whole thing. The text also, to complement these theoretical teachings, the sutra also included a corresponding meditation methods. So within the text, there's not only the theory of why there's suffering, and there's the path to ending suffering, is also proposed a meditation methods to go with the whole thing. Okay? So the ultimate aim of this practice is to enable the practitioner to see the emptiness nature of phenomena or the three types of essencelessness, so that one will be able to eliminate the delusion and attention, which are the roots of suffering. So this is the whole theoretical foundation of the whole program. So now there's the pedagogy, how we're going to introduce this teaching. Obviously, the Buddhist pedagogy is the wisdom from learning, and then the wisdom from that. In this, then we use lectures and discussions and notes to give out to our people to participate in the program. And then wisdom acquired from thinking and analysis. To help the clients to do that, we give them exercise, we give them homework, revision exercise, and group discussion, so that they can learn more about the teachings that we introduce to them. And then the wisdom gained from direct experience. So we do that meditations, and then using chanting mantra, and as a mean to develop compassion and wisdom. So this is how we introduce these through these three methods. learning, thinking, analysis, and direct experience. So we help the clients to understand, hope they will understand what we teach. Okay, so we did that. And then the outcome of the outline of the ATP, this is the content of the program. And there's altogether 7 workshops. In the first week, we try to help them to generate aspiration and commitment. We want to commit that if they're going to come into this program, they need to have an aspiration, they want to commit. This is what we want to help them to do the first week. And then learn and experience the power of awareness. So it's an awareness training program. So why is it awareness is important? Awareness is important is because only through awareness that we can transform. Only through awareness that we can go from suffering, from not knowing to knowing. So we want the clients to see that no matter how much you suffer now, what stage you are now, through awareness you can develop wisdom and understanding, and through this wisdom and understanding you can transform yourself. So we want them to know that the power of awareness, this is what we want to introduce them in the second week. And then the third week is that recognizing and understanding the universality of suffering to generate compassions. We want them to see that it's not only that they themselves are suffering, everybody else is suffering. There's a lot of suffering is going on, but the suffering is something that we hope them to, with this understanding of suffering, we hope them to generate compassion, not only to themselves, but to everybody else. So on the 4th day, cultivating compassions for oneself and others. Oh, forget that. We teach them meditation from week 1. Okay, it's going on all the time. Cultivating compassions and for oneself and others, and then cultivating a deeper understanding of the concept of self. So this is what was going on during the retreat, and then developing wisdom through understanding and experiencing the 3 kinds of characteristic and the 3 kinds of essences characteristic of phenomena. I must congratulate ourselves to be able to introduce this complicated concept to our clients. This may sound complicated to you, but I have data to show to you that it works. And then discovering the meaning of life. And then week 7, summarizing learning experience and developing sustainability of practice. So this is the outline of the ATT program. And we actually did it. We have data to show you. Then Bonnie is going to show you what we did and data, and show you that it actually worked.
Thank you, Venerable Huang. Here comes the empirical research that we have done, and because this is a new intervention, so in order to evaluate the effectiveness of this novel Mahayana Buddhist teaching-based intervention, we have done a randomized controlled trial. By comparing the experimental group with the waitlist control group. And the participants that who participate in our study are those who are the middle-aged working adults in Hong Kong. And the reason behind is because Hong Kong is a stressed-out city. And in fact, the average annual working hours for the Hong Kong employees is far exceeded than that of many other metropolitan cities like London, New York, Sydney, Seoul, and even Tokyo. The working hours in Hong Kong is much longer than other many modern cities. And also a survey also revealed that 97% of the Hong Kong adults suffered from the sub-health symptoms. And the most affected group is the middle-aged group. And also research also find that chronic stress will increase the risk of developing the mental illness and also even death. And the inclusion criteria of our participants include those who are aged 30 to 60, and the working adults, and their education level reach upper secondary or above, because we find that maybe sometimes we also need they need to understand the teachings. It's quite sophisticated, so we want them to have reached a certain level of this education level. And also they reported that at least moderate distress with score 4 or above out of 7 in one of the following aspects, like work, family, love affairs, interpersonal relationship, financial, health, or social environment. And the exclusion criteria include those diagnosed with psychosis or mental illness, and who are currently engaged in psychotherapy, and those who have any intensive meditation training or practice previously. And this is the cohort diagram showing the flow of the participants. Let's see how to use this. Yeah. Okay. And you see that we have recruited 420 people through radio and university-wide promotion at the very beginning. And after screening, according to the inclusion and exclusion criteria, we have randomized 122 participants evenly into 2 groups, into the experimental group, and this is the control group. I won't go through the details about the dropouts and the reasons of the dropouts. But the design, you can see that we collect the data at baseline and after the intervention, and also 3 months later. And you can see that at the end of the study, the dropout rate is around 10%. The total number of the participants is around 110. So the dropout rate is quite low as compared to many similar studies. So here is the demographic characteristics of our participants. Similar to many other mindfulness-based interventions, the majority is the female, around 70%, either in the ATP group or the control group is around 70%. And the age is, the mean age is around 46 years old. And you may take a look, at the education level and the marital status of our participants. And in fact, the 2 groups are quite similar, the percentage. And this is the marital status. You can see that. So both groups are quite similar in terms of their education level and the marital status. Since this is a Buddhist teaching-based intervention, I think some of you may be very interested in knowing what are the religion of the participants then. Sorry. Okay, and here comes the religion. In fact, we have well-informed the participants that this is a Buddhist-based intervention. They all know that during the recruitment and during the screening, we have told them that this is a Buddhist-based intervention. And then, but we found out that eventually around 60-something or nearly 70% of the participants are those who do not have any religion. And about 1/4 of them are Buddhists, and then the rest is Catholics and Christians and other religions. For the measurements tools that we have used, for the self-reported psychosocial questionnaires, we have measured the perceived stress scales. It is to assess the levels of the psychological stress. And then it's the orientation to life questionnaires. This is the SOC 13, and it is assessing the ability to cope with stress. And then the general health questionnaires is assess the psychological well-being of the participants. And the last but not least is the non-attachment scale that I think in this afternoon, Venerable, Dr. Wayne Gordon has also mentioned about this scale. And you see that we don't have any scale about the compassion because we can't find any existing scales that fits our study. So we didn't use it, the psychosocial questionnaires about the compassion. But instead, we used the neuroscientific measures to assess the effect of the compassion. And we used the EEG to collect the brain electronical signals escape, and also the ERP to measure the instant brain response to emotional stimuli. And in addition, we also measure the physiological, we also use the physiological measures. We use the ECG to measure the physiological changes of the heart induced by the emotional stimuli. So in this part, I will present about the results of the self-report psychosocial measures. Before analyzing the data, we try to figure out if there is any differences in the characteristics across the groups at baseline. And the results we find that from the chi-square test and also the independent sample t-test, the participants did not different in their demographic characteristics. And also, we also used the TOES test, and the equivalence criterion was set at 20% of the mean of the ATP group, and which find that the various psychological scores and age between these two groups were found to be equivalent at baseline. And to assess the robustness of the results, we have used the intention to treat analysis as the primary analysis, and then we also use the per-protocol analysis as the secondary analysis. About the ITT analysis, we use a more conservative method. We have included all the participants once they have randomized. And also to see because we have some dropout data, and then we have to perform the MCAR test that we found that the data were missing completely at random. So to address the missing data or the dropout data, then we used the multiple imputations to address these data. And 20 input data sets were produced for the data analysis and also for pulling the results of the ITT analysis. For the secondary data analysis, the per-protocol analysis, we have used this right deletion. So I'll firstly present about the ITT results. Okay. This is the perceived stress scale. How to interpret this? The score, for the lower the score, that means the levels of the stress is lower. So you can see that this is the purple line is the ATP score, and the red line is the control group scores. This is the mean score of the two groups. And then the results, in fact, it shows that the improvement over the controls from baseline the baseline to the post-test, and also to the post-free in the ATP group. And for those who know about the statistics, this is the results of the two-way mix ANOVA for the overall interaction effect. And this is the p-value, which is highly significant. And this is the effect size, and this is the overall effect size. And this is the intervention effect size, effect size. And this is the maintenance effect. And how to interpret the effect size? Normally, for the partial eta square, the effect size small is 0.01, and medium is 0.06, and large is 0.14. So you can see that our effect size is from medium to large. And this is the sense of coherence, and the score, for the score, the higher the score, the better the results. And so you can see that this is the ATP group, and this is the control group. This is also the mean score. And also this result is highly significant, and the effect size is medium. This is the general health questionnaires, the results, and this is also how to interpret this. The lower the score, the better the psychological health. So you can see that ATP dropped drastically from the baseline to the post-test and then to the post-free. And it is also highly significant, and the effect size is very large. This is the non-attachment scales. The higher the score, the higher the levels of the non-attachment. And then you also see that for the ATP group, it rises drastically from the baseline to the post-test, and then it maintains at the post-free. And this is also highly significant, and the effect size is large. And I will briefly talking about the results of the PP analysis. And this is the results of the PP analysis. And in fact, I will not go into very details, but you can see that the results of the PP analysis were very similar to those of the ITT analysis presented above, but with a higher significant difference. I didn't show the significant difference here, but you can see that the effect size is larger than that of the ITT analysis. That means that the results is very consistent. So we have also done the mediation analysis. For those who are not very familiar with what is mediation analysis, a brief explanation is that the mediation analysis is a hypothesized causal chain in which one variable affects a second variable that in turn affects a third variable. And in our study, we hypothesized that wisdom in the form of non-attachment will be the mediating factor of the outcome measures. Okay. Here is the mediation diagram summarizing the hierarchical linear regression and the bootstrap analysis using the NAS, the non-attachment, as a mediator of the effect of the intervention on stress at post-test. And you see that this is the p-value, and the red one is the results of the hierarchical linear regression, and the black one is the results of the bootstrap analysis. And the number in this blanket is the beta after controlling for the mediator. And the numbers in this bracket is the CI, and this is the lower confidence interval, and this is the upper confidence interval. And if you want to compare the two results, you can see that if the 0 is not included within the estimate confidence interval, it indicates a significant mediation effect at the 0.05 level. So you can simply take a look about the results. You can find that this is significant, and then after controlling the mediator, it becomes less significant. And the results of the two analyses is very similar. So all the criteria to establish the mediation has been met in this model. And this is also the same case on the, if you use the NAS as a mediator of the effect of the intervention on the sense of coherence as post-test. You see that the results is also very similar. And also for the GHQ, all the criteria has been met to establish the mediation. I don't want to be tedious, and so we also performed the same analysis on the post 3 months, and we got similar results. Okay. A brief conclusion about the results of the self-report psychosocial measures. The findings indicate that ATP is effective in improving the stress levels, the sense of coherence, psychological well-being, and wisdom of non-attachment of the middle-aged working adults. And these improvements were maintained at the 3 months follow-up. And we also find that the wisdom in the form of non-attachment serve as a key component of ATP to mediate the improvement of the levels of perceived stress, sense of coherence, and psychological well-being. And in the coming part, Venerable Huang will present about the neuroscientific experiments.
Okay. The reason that we use neuroscientific experiments because we want to be more assured of the results or the effect of the program. And furthermore, we have problem of trying to measure the effectiveness of our compassion meditation. So we did a neuroscientific experiment. We actually did a lot of them, 6. I'm only going to report the number 3 and number 6. So what are these? The number 3 is to investigate the impact of the ATP on the psychological priming effect of the Buddhist concept of compassion and wisdom on a person's neuro response to negative and neutral pictures. So that means we're going to measure these people, the ERP and ECG. And the hypothesis is that compassion and wisdom may influence different brain area and at different stages of emotional information processes. So in this presentation, we focus on the ERP and the compassions. The other is I'm not going to present them. Just the ERP is Bonnie just explained to it. We did 85 participants because some were not able to come and they kind of dropped out. They could not come to the measurements. Measuring because we need to come to the office and then we put them the EEG machine and the head and all that. So the study is we use the E prime, and then also the pictures were set up to the IAPS, and the internet variance was also the EEG machine was 128 channel EGI machines. So this is the machines that we use. What we did was the priming with wisdom cue. Then we asked them, life is, when we show them these horrible, pictures, and then ask them to look at these wisdom cue, and that is the life is nothing but a dream and bubbles. And then we also showed them that priming with compassion, may you be free from suffering and difficulties. And then priming with neutral cues, reality of life. And then priming with neutral cue, reality of life. This is looking at neutral pictures and looking at negative pictures. So when we show them these negative pictures, while they look, when we hook them up with the machines. So these negative pictures, they look at them. The data analysis, we use the MetaLab and the EEG lab, and then well, I don't want to bore you with all this stuff. But anyway, this is the things that we use. So so what is this? The effect of compassion priming. The figures demonstrate that time series of brain response to negative pictures. So this is the first one is the time. This is the ATP group. This is the control group. This is the ATP minus control group. So that minus that is equal to that. Okay. So this is the time. The first time is 0 to 200, and then this is the 100 to 200. And these are the time after they see the pictures. This is in microseconds. And the beginning is just they look at the pictures, and then after they look at the picture, at around the 300 and 400 microseconds, then the emotions come. So we want to see the figure demonstrate the time series of brain response to negative pictures with compassion priming versus neutral priming. For the ATP group, these people, control group, these people, and the difference, this minus that, okay? So what happened is that the upper 2D map, these are the map, for the whole brain in 5-time window, just at the time I just showed you. The lower curved line charts show that the brain signal of channel 3F, that's only one of the channel, when we show you one of the channel. The channel around here, okay, okay. So what we found is that priming of compassions induce significantly more frontal activities at N400, that's the 400 microseconds after they first saw the pictures, in the ATP group when compared to the control group while viewing negative, miserable pictures. So there's nothing here, there's no difference. We cannot see any significant difference in the beginning because when they both saw the pictures, it was the same thing. And then again, not very much happened. And then it started happening over here, okay? So this is the most important. Yep, this is the most important area that we found a significant difference. So what this means is that that actually these people that were practicing the compassionate meditations, when they compare the control group, when we show them these miserable pictures, that those people that went through the program and practiced compassionate meditations, they were actually more compassionate when they look at these miserable pictures, when we measure them with these EEG machines. So basically, the observation is that these people that went through the program were, in their neuro response, that they were actually more compassionate. Okay. So this is the area where you use source analysis and analyze which part of the brain it is. The source analysis using SPM suggests that the brain region that is most significantly activated by compassion priming is the medial prefrontal lobe, which is often associated with empathy and compassion. So what's supposed to happen actually happened. That's very important. This is the part of the brain that when you are compassionate, that's the part of the brain that's activated. Okay, this is what we found out. Okay, so this is the area. Okay. So this is the second experiment. This experiment is the study of effect of the compassion management on ATP participants. This is among the participants themselves, between the person when they are practicing compassion and when they are at rest. Okay, there's 45 participants, and because we only measure the ATP group participant because the control group, they did not learn compassionate meditation, so we cannot measure them. Okay, so the normal rest versus the compassion meditations, this is what we compared them. During the 15 minutes compassion meditations, we only took the first 4 minutes because some were better, and so we only took the first 4 minutes. Okay, this is what we found out. The 3D estimations show that significantly higher EEG amplitude in the anterior cingulate cortex of the frontal lobe during compassion meditation when compared with the resting state of the ATP. So these guys, when they were meditating, supposedly doing compassion meditation, this part of the brain, which also is associated with the compassion and empathy, actually they were activating when they're comparing to themselves. So again, to prove to you that the compassion meditation was actually working for these people. So so this is what we found out. The conclusion from the news: the ATP control, the training could effectively modulate the participant emotion when viewing negative and miserable pictures. Compassion training taught in ATP induced more prefrontal activities. Together with ERP and EEG experiment, it implies that ATP training enabled the participant to develop more compassion related with neural activities. So this is what we found out. So the implication: the development of ATP and the finding of this study demonstrate that Mahayana Buddhist teaching-based intervention, which adopt a textually aligned approach with a coherent theory and practice, could be effectively means to enhance people's psychological health and well-being. The result provides a solid foundation for future study to further investigate the effectiveness of ATP Since this is the first attempt to develop and investigate an intervention that adopts a textually aligned approach, the positive finding may inform researchers' future research approach to formulate and design Buddhist-derived interventions. So this research was funded by the Lee Ka-Seng Foundation. So thank you very much.
Thank you very much for Venerable Ken Hong and Bonnie's very detailed presentation. So,
any questions? Yes. Oh. Hi.
Can you explain why in all the graphs that we show, the control group started off being a lot better in every respect than the ATP group, and yet it was supposed to be a randomized collection? Isn't that correct?
It was. They were a little higher, but according to statistics, they were not significantly higher. Am I right? Yes, they were not significantly higher. So they were statistically not significant. So that's why the baseline is identical. I mean, the baseline was okay.
But in the first graph, it was quite a large change. I mean, the difference at the beginning difference between the two was larger than the ending difference between the two in actual fact. Is that correct?
Well, Bonnie reported.
I mean, I agree what you say. Statistics. But
yeah, but why we don't know. That's what we did. That's what we found out. That's what we took down. And so. Which one? Which one are you talking about?
Yeah, this one.
Oh, so this is not.
Oh no, I'm wrong.
Yeah. It's okay.
Yeah, it's about 2 this and 2 on the other end, right? Isn't it?
But show them the baseline chart.
Yeah.
The baseline, because the baseline statistics were actually there was no significant difference. Yeah. That's all that we can say.
Maybe you look at the graph, it seems that it's very large, but to look at this, the numbers is 20.75 and the other is 22.15. So it's not that large, in fact. And statistically, it shows that there is no significant difference between the two groups, and even for the equivalent test, and they found that they are very similar. Yeah.
Yes.
Thank you for a very interesting presentation. I have 2 questions. The first question is the ATP group. At the very beginning, 66% is no religion, and only 25% have the Buddhist religion. And I want to ask the EEG, the end of the result, that is 42 participants who have done that, then these 42 participants, is it any significance? They have the Buddhist religions before? So I don't know, these 42 participants is a lot of no religion that after finish this ATP program have this significant compassionate meditation effect. So this is the first question.
I don't know. The question is what? What the question is?
The first question is I want to know after this ATP program that 42 participants actually to have the EEG and also have shown the significant compared with the control group. Then this 42 participants, is it a lot of the people have the Buddhism, the religion before, or this is a lot of participants is no religion before?
This demographic characteristic was taken before they participate in the program. So after the program, I don't think we don't know that they changed the religion. I mean, it was not reported to us. Maybe some of them, we know some of them had came to enroll in our Master in Buddhist Study program. Maybe it's one way to sell the program, but we don't really know that they took refuge or anything like that. No. I think some of them might have, but it was not our intention. And they participate in our ECG measurements. At that time was at the end of our program that we took the measurement. So I think it's on the ATP group people. So we did not take down what the 40-something people was with their religions of that. We can go back and check. But I don't think that would make any difference. I mean,
Thank you. The second question is, I'm interested about the ATP group. In the week 4 and week 5, I have a whole day retreat program for cultivated the compassion for oneself and others. Could you tell more about the activity? We are very interesting. Thank you very much.
The activities. Well, actually, there's a little difficulties because
is walking meditation, holding a bowl of water, or sitting meditation?
No, none of that.
Or chanting?
No, we actually taught them the Om Mani Padme Hum mantra. And you can come to our workshop tomorrow. And we will be introducing the meditation method that we use in the ATP program.
So you teach them to chanting the
Om Mani Padme Hum, and then we develop a mantra. Not a mantra, a poem or summaries of the meaning of Om Mani Padme Hum. And we ask them to memorize that and contemplate on the meaning of Om Mani Padme Hum before they chant the Om Mani Padme Hum. So is that they chant the Om Mani Padme Hum. When they chant the Om Mani Padme Hum, they would have the meaning of Om Mani Padme Hum. Is the meaning and the chanting working together that create the effect of the meditations.
Yeah. We have another chanting of Nam-myoho Renge Kyo. That means the chanting the Lotus Sutra.
Yeah.
Yeah. So another chanting is Nam-myoho Renge Kyo. So that is very interesting to you teach some people to Amma Padme Hum. So thank you. Yeah.
Thank you very much. And I think we may not have enough time to answer all the questions. Maybe the last one?
Thank you so much for your great presentation and great research. I have one question. Is compassion the key to non-attachment in this ATP model?
We look at non-attachment as wisdom and compassion as compassions. We intentionally to develop the two separately. However, what I say separately is that when we try to help the participant to develop the two things, we have two different activities focusing on compassions and different activities focusing on non-attachment. So obviously the non-attachment and compassions, they are interrelated, they support each other. But when we, the activities that we have target towards this are separate. It's a complex intervention, and yeah.
Thank you so much for your compassion.
Okay.
Thank you, Venerable Hin Hong and Bonnie. I hope you all find the presentations today beneficial. And could I invite you all to give another big round of applause to all our speakers today? Thank you so much for all your beautiful presentations. There will be 4 more presentations tomorrow morning and workshops in the afternoon, so please don't miss it. The session tomorrow will begin at 9 in the morning, same lecture hall here, and we hope to see you all again tomorrow. Thank you and have a nice evening.